Hi guys, welcome back to my channel. So today let's discuss about cervical cancer. In particular, I am going to discuss about incidentally detected cervical cancer. Suppose a patient has symptoms of irregular menstrual cycles or postcoital bleeding, or if there's any white patch on the cervix. So she undergoes conization and on loop or laser conization, and the final report turns out to be cervical cancer, and the stage is early. So what is early and advanced cervical cancer? What stages come under this? So, in early, it is figure stage 1A, 1A1, and 1A2. Stage 2, stage 1B1, 1B2. Whereas in advanced, any tumor of size more than 4 centimeters, that is 1B3. The only exception, there's anything more than 1B3 is advanced, except the only exception is stage 2A1. Because here again the size is less than 4 centimeters and it is involving only the upper two-third of the vagina. Upper two-third of vagina involvement is usually resectable. So with this background in mind, let's see for each stage how we manage these patients. Because we often encounter these patients in clinical practice, so we need to know what we should do for these patients. Now coming to stage 1A, 1A is further divided into 1A1 and 1A2 depending on the depth of stromal invasion. It is less than 3 mm, or if it is 3 to 5 mm stromal invasion. So in these patients, if the margin is positive, then a repeat conization should be performed. Whereas if the margin is negative, then we should look at LVSI, lymphovascular space invasion, whether it is absent or present. If LVSI is absent and if it is stage 1A1, either FIGO or T stage 1A1, both are the same. If LVSI is not there, then the patient should just be observed. If LVSI is positive, then these patients should be considered for SLNB. Similarly, in 1A2, if the LVSI is absent, then you can consider these patients for observation or SLNB. If LVSI is present, then these patients should undergo SLNB. Although pelvic lymph node dissection is not necessary. Next, moving on to stage 1B. Stage T1B is divided into 1B1 and 1B2, whereas in FIGO there's 1B1, B2, and B3. So for 1B1 and 1B2, these patients should undergo lymph node staging. Lymph node staging can be performed minimally invasive approach. So in this, a laparoscopic PLND is performed. A laparoscopic SLNB is performed. And if pelvic lymph node is positive, then these patients should undergo definitive CT-RT or just RT, depending on the risk categories, which I'll discuss in the next topic. If pelvic lymph nodes are negative, then perform para-aortic lymph node dissection, then perform para-aortic lymph node dissection and perform a radical parametrectomy. Coming to stage 1B2, where the tumor size is more than or equal to 2 centimeters. If there is no residual disease on imaging and the margins are free, then these patients should receive radiotherapy. And if there's margin positive, then if you can revise the vaginal resection margin, then you can go ahead with revision vaginal resection margin, considering the SLNB is negative. Or you can consider these patients for definitive CT-RT. So what is this risk group that I'm talking about? So there are 3 categories: low risk, intermediate risk, and high risk groups. Low risk depending on size, stromal invasion, LVSI. If the size is more than or equal to 4 centimeters, or if the stromal invasion is more than 50%, or if LVSI is positive, as per the said list criteria, these patients are candidates for RG. Coming to high risk, if the mnemonic is LMP, lymph node positive, margin positive, or parametrium is involved. As per Peters criteria, these patients should receive CTRT. If none of these are present, then it is considered as low risk. Now let's discuss the concept behind SLNB. How is it performed? So, zero point 0.5 ml of ICG is taken and is injected. SLNB, preferably ICG, is used as per the film's trial, injected at two locations at 3 o'clock and 9 o'clock, submucosal and stromal, 1 centimeter deep, and all the marked or suspicious lymph nodes should be sent for frozen section without any fixative, and these should undergo ultrastaging. If on only on one side you identify the sentinel lymph nodes, then you do SLNB on this side and systematic pelvic lymph node dissection on the other side. What is systematic pelvic lymph node dissection? This starts from common iliac till the circumflex iliac vein. It includes lymph nodes from the common iliac, internal iliac, external iliac, obturator fossa, and the presacral nodes. This is called a systematic pelvic lymph node dissection. Whereas on the side where the uh, fluorescence is seen, then that side only SLNB is enough. Recently published Phoenix trial has shown that SLNB alone is enough. No need to perform PLND if the SLNB is negative. And they have shown non-inferior disease-free survival in both the groups. So that is if the SLNB is negative. What if SLNB is positive? If single node is positive, then you perform para-aortic lymph node dissection and abandon the surgery. If these later turn out to be positive, then your field of dissection, field of radiotherapy is extended RT. Whereas if at least two SLNB are already positive, then there's no point in performing para-aortic lymph node dissection. These patients anyway require an extended RT field. You can straight away abandon the surgery. Because lymph node positivity upstages the tumor to stage 3, and which requires definitive CTRT. So that is about management of incidentally detected cervical cancer.